Hello, everybody, and welcome. Today is Therapy Thursday, May 25th, 2023. I'd like to welcome you all to this edition of Therapy Thursday. My name is Evan Adler. I am a physical therapist here at UNC Therapy Services, and I'm a representative of the Community Engagement Committee who have developed this online series to bring you physical therapy and therapy related topics here in a online digital fashion. This grew out of COVID, where we typically had been reaching out to people in person and hands on, face to face, and then we needed to figure out a new way to do that. And this became pretty successful, so we kept on with it. So in the let's see, a couple of points of order. So in the chat, if you are able to see the chat, if you're on your computer or your smartphone, you will be able to see a couple of links that I've put in there. One is for our YouTube channel, where you can find other editions of Therapy Thursday with a full range of topics, including other women's health, pelvic health topics, all the way through arthritis, knee pain, hip pain, back pain, running stuff, all sorts of good stuff. So I invite you to really go take a look, subscribe, and take a look at the videos that are there. The other link is for our Facebook page for UNC Therapy Services, and that's where you can find all sorts of different events that will be going on, both in person and online. So I invite you to go ahead and follow us there. Okay, so with that said, today's topic is one that I have zero practical knowledge about. And as I said before, I refuse to be mansplaining any of this today. So I'm going to turn the presentation over to Gianna and Sarah in a moment here, but I will like for anybody that does have any questions, you can put it there in the chat. And if it's something urgent, we can answer it on the spot. If not, we're going to wait to have questions at the end. Okay, with that said, I'm going to remove myself from the situation and turn it over to Gianna. Take it away.
All right, so hi everybody. Thanks for coming to our presentation. Sarah and I are really excited to be presenting this information to you all. And so our presentation is called The Period Before the Menopause. So essentially what we're going to be talking about today is menstrual cycles as well as menopause and how physical therapy can help with that. So Sarah and I are both the women's health physical therapy residents, and we're excited to be providing this information for you. Okay, so to start, to have an idea of what the pelvic floor is kind of the baseline of where we want to start at. And Sarah and I, in the field of women's health for physical therapy, have a lot of knowledge and a lot of practice with the pelvic floor. So just knowing exactly what that is, if we look at the pictures over on the side, you see two pelvises there. And so at the top picture, the pinkish reddish area at the bottom of the pelvis, those are your pelvic floor muscles. And that angle is looking down within the pelvis versus the bottom picture being a view looking up at the pelvis. And so you can see that those pelvic floor muscles are connecting the bottom of the pelvis and acting almost as a support or kind of like a hammock to the pelvic muscles or to the pelvic organs that would be over top of those. So that would be anything like our reproductive organs, our bowel, our bladder. Those are all going to be supported by those pelvic floor muscles. Another thing that's important in a way to remember the functions of the pelvic floor are the 5 S's that I have listed on the side. And so the first one, having the support. So again, the pelvic floor is going to act to support our bladder, our organs, and our bowel. Also acts for sex, helps with sphincter control, so preventing anything like leakage of urine, leakage of stool, It also acts to stabilize the pelvis. So it's acting to not only provide us stability, but to provide even some balance as we're going through our tasks and completing our things throughout our days. And then the last S is for some pump or circulation. So the pelvic floor is going to act to move the blood flow from the lower extremity or from the legs and move it up toward the heart so that it can be recycled and move throughout the system as a whole. Right. And so now getting into what our main gist of our presentation is, we're going to start way back at menstruation. So essentially what menstruation is it's going to be the shedding of the uterine lining. It's important to know that menstruation is going to differ from a menstrual cycle because menstruation is going to be the time of the shedding of the uterus, which is that smaller duration of time, whereas the menstrual cycle is actually going to be multiple different phases, but it's going from the beginning of the menstrual cycle to the beginning of the next menstrual cycle. So it's a longer period of time that you're experiencing the menstrual cycle versus just menstruation in itself. And so menstruation is going to be driven by our hormones. And once those hormones get released, it leads to the thickening of the uterine lining. And so when the egg is then released, if it doesn't implant into the uterine lining, say if pregnancy is occurring, that's when that uterine lining is going to start to shed, leading to the menstruation. Next slide. And so these are some normal menstruation symptoms that we should all be aware of. So knowing the normal length of a menstrual period is going to be about 3 to 7 days versus the normal length of a menstrual cycle. On average, that's going to be 28 days. Again, that's going to be measured from the first day of the menstrual period to the next or to the beginning of the next menstrual period. So on average, that's going to be 28 days or still within normal ranges being from 25 to 35 days. Normal amount of time or normal ages when the menstruation will start could be at age 12 on average, but it can be from ages 8 to 16 and still be considered normal. A normal amount of blood loss can be considered 1 ounce to 30 milliliters. That can be a little bit hard to gauge on our end. I know I'm not, measuring anything in that way, but another way that we can kind of have a better idea of how much blood we're losing is how often we're changing our feminine products. So if we're changing it 3 to 5 times a day, especially during those earlier, heavier days, that's considered within normal range. And then you might notice some other symptoms like mood changes, trouble sleeping, headaches, food cravings, bloating, breast tenderness, and acne. And you can experience maybe all of those symptoms, or you can only experience a couple of them. Everybody's going to be different. And it's not to say that if you aren't experiencing those symptoms, that something's wrong. But it's just important to know what symptoms you experience and how they impact you during this time. And so now, here are some of the symptoms that might be considered abnormal when it comes to menstruation. So, if you're having a menstrual period or cycle that's less than 21 days between, or if they're greater than 35 days between, possibly not having a period for 3 months at a time, having a flow that's maybe a lot heavier or a lot lighter. And again, you can kind of gauge that by how many feminine products you're using. If you're using multiple throughout the day, going over that 5, that could be a key that maybe things might be a little bit abnormal. Or maybe not using as many, so maybe only using 1 or 2, that could also be a sign. If your periods are lasting longer than 7 days, if you're having severe pain, cramping, nausea, or vomiting during your menstruation period, as well as if you're having any bleeding or spotting between the periods. Those all can be considered possibly abnormal. And so now going into the different dysfunctions of menstruation, there are a couple different types that I have listed here for you. So the first type is dysmenorrhea, which means pain with menstruation. So that's your painful cramps, your um, painful stomach pains, anything like that would be considered within that category. And there's two different types of dysmenorrhea. So there's a primary dysmenorrhea as well as a secondary dysmenorrhea. Primary dysmenorrhea could possibly be linked to the symptoms coming from the uterus itself. So the contractions, the cramping, the pains coming from there. Whereas secondary dysmenorrhea, that's going to more so be possibly coming from something outside of the uterus. So maybe something like endometriosis or uterine fibroids or anything like ovarian cysts or um, anything like the contraception, like IUDs. Those could also be things that are leading to pain during periods. Um, Oligomenorrhea as well as amenorrhea, those are pretty close together sometimes. So oligomenorrhea is going to be abnormal or irregular periods, whereas amenorrhea is going to be lack of a period. And so sometimes those can kind of play into one another, especially if your periods aren't on a consistent route. Um, and some things that can lead to either one of those could be a delay in puberty, it can be hormonal changes, it could be stress levels, it could be vigorous or high intensity exercises that are causing a shift within those hormones, possibly causing something like an imbalance or anything like that. Um, or even changes in diet or weight loss or weight gain. The next one is menorrhea, which is going to be heavier periods. And then the last one is going to be hypomenorrhea, which is the opposite, having lighter periods. So, some risk factors that could potentially lead to some dysfunctional menstruation could be if you had your menstruation prior to the age of 11, that can possibly put you at a higher risk for having severe pain, having longer periods, or having longer menstrual cycles. Possibly being overweight or underweight can lead to some shifts or dysfunction with the menstrual cycle or the menstrual period. Having longer or heavier periods to begin with. Pregnancy history, especially with the change in the hormones as we go through that phase of life, that can lead to some alterations in our menstrual cycles. Smoking, stress, or exercise could also be possible risk factors to those changes. And so, where do we essentially come into play? So, it's important to know that um, anyone in the pelvic health physical therapy world, we're not necessarily going to be able to change the period. So if it is dysfunctional for all of those different underlying reasons, that's not something that we're going to be able to improve. But we take a look at things from a muscular standpoint and from a body standpoint. And that's where we're able to come in and help with symptoms. If having those abnormalities lead to issues within the muscles throughout the body, especially at the pelvic floor. And so that's something that we'll examine. We'll take a look at the pelvic floor and we'll be able to assess the strength of the pelvic floor, if there's any tenderness, tension, looking at coordination, just looking at overall mobility of the pelvic floor. And we can actually improve that within the session and teach you ways on how to improve that on your own. And so when we go into the evaluation, um, it's important to note that when you come to see a pelvic floor physical therapist, we all have private rooms and we're all typically one-on-one. So when you come in, it's just you and the therapist, and then we just sit down and we have a conversation about the symptoms that are bringing you in today. And so we not only will ask questions about the period, but we're also going to be taking into consideration pregnancy history, intercourse, if there's any pain with intercourse, um, bowel symptoms, bladder symptoms, because those all can play into what could possibly be happening with the periods, or vice versa. It's hard to say which one because there's never truly a cause, but we can take a look at the whole picture and then be able to address those portions that we might see some dysfunction with. And so once we do the subjective history and just chat about different things, then we'll go into our objective measures. And so that would entail us not only looking at the pelvic floor in itself, but also looking at the whole body. So looking at how you move, how you maybe pick up objects, looking at areas surrounding the pelvic region, like the abdomen or the low back or the hips, because if you have some dysfunction there, it could be also leading to dysfunction at the pelvic floor, or the dysfunction at the pelvic floor could be leading to some of those symptoms. So that's why it's important we get an idea of the whole picture, because then we're able to address those different areas. So following looking at those different areas, oh, hang on, go back, Sarah. So we'll do the pelvic exam, and what that will look like is it's similar to a gynecological exam. And so we won't use stirrups, we won't use equipment, we just use a gloved finger and lubricant. And we're able to look at the pelvic floor and touch on those different areas to see where some dysfunction might be and work through that with you within the session and in future sessions. Typically, the length of time that we would see a patient, it could be 8 to 12 weeks, but it really just depends on how long the symptoms have been going on for, different factors playing into the symptoms, if there's any barriers to getting to the therapy or getting to physical therapy, that can also either shorten or lengthen that time frame. But generally, it's going to be about 8 to 12 weeks. And so, based off of what we find in the pelvic exam and doing an examination of all other symptoms, we can then come up with different treatment and interventions that not only we'll do in the clinic, but something that you can also do at home to address your symptoms on a regular basis. And so, what can physical therapy do? So, as far as the dysmenorrhea and the different abnormalities of the dysmenorrhea or with menstrual cycles, with dysmenorrhea, like I said earlier, we're not going to necessarily change anything per se with the menstrual cycle or the menstrual period, but if there is any pelvic floor tension or abdominal tension or low back pain or hip pain that could be caused by that, that's something that we can address within the session. Typically, what can happen is if you are having a lot of pain, our body will naturally guard itself. So we'll kind of pull ourselves in and hold tight. And that can lead to dysfunction within the pelvic floor or those varying regions around the area. And so if we go down to amenorrhea or oligomenorrhea, again, we're not going to change the symptoms of the period, but whatever we find on the exam, we can address within the session. And with menorrhea or hypoamenorrhea, still not going to be able to change how heavy the flow is or how light the flow is. But if there is something like stress that's leading to those symptoms or those changes, we can talk about ways to manage stress better within the session. Or if it's coming from vigorous or heavy exercise, we can again maybe look at your exercise program and make some adjustments there. And so, further management, if you do notice some changes in your period or your menstrual cycle, it's important to make an appointment with your gynecologist to really find that underlying reason of what could be causing it. So, knowing those normal signs and symptoms are going to be extremely helpful, not only to you in knowing what's going on with your body, but also when you're presenting this information to the doctor, it gives her or him a better idea of what could be leading to these symptoms and seeing how long it's been going on for. And ways that you can do that is paying attention to your symptoms and then if they change, but also tracking your periods can be a really good way. And there's various different apps that you can use to track your period that can hold you more accountable to what your period will look like, or even just marking your symptoms on a calendar. And so then lastly, coming to see a pelvic PT so we can address all the symptoms that could lead to the dysfunction that we find within our evaluation. And then hopefully by the end, we will be able to give you back a better quality of life and improve your overall symptoms. Right.
All right, so my name is Sarah, and I'll be talking about menopause. So, what is menopause? There's three main stages. You can be perimenopausal, be in the stage of menopause, and then postmenopause or menopausal. So, perimenopausal is the time leading up to menopause, and it can actually be around anywhere from like 8 to 10 years. Menopause happens on average at the age of 51 in the United States, but perimenopausal can start in your 40s. And so menopause is the time at which you've gone 12 consecutive months without a menstrual cycle, so without a period. So if you went 11 months and then at the 12th month had a period, that would still be considered premenopausal. And then postmenopausal is that time immediately after you've gone the 12 months without a period. So it's kind of weird because you'd go the 12 months and realize that that 12 months was your, the time of menopause, and then you'd be postmenopausal. So then what are the causes of menopause? When you are in the perimenopausal stage, your ovaries are gradually producing less estrogen. And when you're in the menopause stage, ovaries have stopped releasing eggs and producing any estrogen. And then in that postmenopausal stage, it's you haven't had your period for years, so all of that egg release and estrogen production has stopped. You can also experience early menopause, and this is usually directly from something like if you've had a hysterectomy, you would then not be able to produce if they've taken the ovaries, the eggs, or the estrogen. Or if you have primary ovarian insufficiency, meaning that they're not working the way that they should, or it can be induced by chemotherapy, autoimmune diseases. So a lot of other things can be going on. Some of the symptoms of menopause include hot flashes, night sweats, vaginal dryness. You also get dryness of other areas like your skin, eyes, and mouth. You can get urinary urgency. With that can come frequency and leaking. You can have difficulty sleeping, tenderness of breasts, heart racing, joint and muscle pain, changes in libido, difficulty concentrating or memory lapse. You can gain weight, hair loss or thinning. You can get reoccurrence of your premenstrual syndrome, like PMS symptoms. You can also have those irregular periods and that time leading up, so they can be lighter or heavier than usual. And you can have emotional changes as well, along with headaches. So, all of the really awesome things that go along with period, plus some extra stuff. So the diagnosis, how do you know you have menopause or have reached that stage is when you've gone that full 12 months without a period. So tracking period can be really helpful because a lot of times doctors will ask when your last period was, and even if it's been 6 months, it can be really hard to remember. So then complications that can happen is there can be very heavy bleeding associated with. We can also see an increased risk of osteoporosis, and that's due to the hormone change because estrogen is important for new bone production. And so when we don't have estrogen, we can see a decrease in our ability to be laying down new bone. And then we also have an increased risk of cardiovascular disease because estrogen is actually protective against heart, like cardiovascular disease or having a heart attack. So women who are postmenopausal are more likely to have an incident of a heart attack. And we can see urinary incontinence. And so estrogen causes the vaginal tissues and the like lining of your urethra to thin out. And so when we have that lack of support, it can lead to us leaking urine. And you're also at a greater risk for urinary incontinence if you're a smoker or are of a heavier weight. So what does the management for menopause look like? Menopause is something natural that our bodies are supposed to go through. So in most cases, no treatment is needed. But if there's cases where we're having a lot of symptoms that are very irritating, such as the hot flashes or the vaginal dryness leading to pain with intercourse or urinary leaking, that's when your gynecologist can step in and help with some hormone therapy replacement that could really relieve some of the symptoms of like the hot flash and the night sweats. And that can either look like a pill, a patch, a cream, a vaginal ring, a gel, a spray. But then you also have pelvic PT physical therapy that can help with those symptoms of, just like Gianna touched on before, if we have pain or uncomfortable, if the muscles are super tight, or if we notice that there's weakness, or if any behavioral changes come about, like feeling like we need to pee all the time, or frequently going for fear of leaking. So what can pelvic floor PT do for you? So the management of symptoms, like we've already kind of talked about, the main ones that we see and can help treat are urinary incontinence, pain with intercourse, osteoporosis, pelvic organ prolapse, and that's when one of the walls of the vagina kind of sink in, either from the bladder or the rectum pushing down, or it can also be from the uterus coming down from the top, or you can see osteoarthritis. So some of the interventions that we have a lot of tools for pelvic pain that can also be used with period pain. And we recommend tools based on differentiating where your pain is. So if it's at the entrance versus deeper in the pelvis. And with pelvic PT, we showed you how to use them, how to be very efficient and effective in their use, and give you exact parameters to help with your symptoms at home so you can manage and not have to be reliant on coming into PT, as we know that menopause, while going through this whole cycle, can take somewhere 8 to 10 years. And so pain with intercourse, we can do recommendations for positionings, use of pillows for support. We can give you exercises to perform before and after to help our pelvic floor be in better shape, depending on what your specific impairments are. And then we can also make recommendations such as moisturizers, lubricants, or the use of vitamin E oil, because we know that estrogen is causing that thinning of the vaginal mucosal tissue. And so a lot of times we start to notice our patients are having pain with intercourse because it's not the same as the tissue used to be. So those moisturizers and lubricants can really be helpful with that. So then other things you might see in physical therapy is the one we all think about, which is Kegels. And the truth is it depends, and there's multiple different types of Kegels. But the important things with these is that when you have a PT do an internal exam, we're able to tell what is happening at the muscles. Therefore, would Kegels be beneficial to you? Kegels are great for helping us strengthen, but if we're having to squeeze our face, which is what this picture is here, our face and our toes and our hands, then we're probably not performing it correctly. And if our muscles are super, super tight, we want to make sure that we can relax them and get them through their full range of motion before we start to strengthen. And if your muscles are tight, we have a wide variety of exercises that we can choose from that help to kind of down train and relax pelvic floor. We have stretches we can give you and different forms of breathing that can actually help to relax and move the pelvic floor. And if your muscles are super weak, we have different ways of strengthening besides just Kegels, and we walk you through them based on, your specific case. So when we talk about the leakage of urine, usually what we do is a pelvic floor assessment, just like Gianna had talked about. We go over the different types of leaking and what could be causing it. We usually classify it into stress incontinence, meaning when you sneeze or cough or laugh or jump, there's pressure on the bladder. And because we have that thinning of the urethra, there's a lack of support, and that can cause us to leak. And we might have weak or tight pelvic floor muscles. So we help address those impairments so that way we can get things functioning to their best capability. We do a lot of education of what's going on for your specific case, and if there's any behavioral changes, like if running to the bathroom is causing us to leak or anything we're drinking. And we talk a lot about pressure management and work on strengthening that pelvic floor since we're losing some support around that urethra. So some useful products that we recommend for everybody is lubricant. I think that everybody would benefit from using lubricant, whether it be with partner or choice. Always recommend it be unscented, non-irritating, free from parabens and dyes, no glitter or anything like that. Water-based is usually better for the sensitive tissues. If you are going to use silicone-based, we recommend you don't use it with any silicone, such as like a tool or a toy, because that silicone on silicone can cause a breakdown. So water-based is our preferred, especially for people who have sensitivities. And then the use of vaginal moisturizer. So we want it to be the same as the lubricant, unscented, non-irritating, free of parabens and dyes. Some really easy ones that people can get their hands on is just generic coconut oil or vitamin E. That can really help with restoring that barrier and getting some comfort back. All right, so we have an exercise that Gianna is going to take us through.
So, one of the foundations to pelvic floor physical therapy, and one of the exercises that most of us always will start with, is doing the diaphragmatic breathing. And so, like Sarah had mentioned, a lot of what we will maybe start with, especially if there's tension at the pelvic floor or even just throughout the body, is doing some down training. And so, this would be kind of like that first step into doing some down training. And so, this is going to be something that we're all going to practice here in our respectful places. Um, and what the diaphragmatic breathing is going to do is if our nervous system is heightened, especially if it has been under stress or endured frequent pain or anything like that, that's going to drive our nervous system up to be upregulated. And so the diaphragmatic breathing is going to essentially give the body the okay to release the tension and allow the nervous system to calm down. So, if you're sitting down or standing, we're going to practice this really quick. So, what you'll do first is you'll take an inhale through your nose, and you want to make sure that you're not having your shoulders rise as you do it or feeling your chest kind of move. You want to feel that breath go into the abdomen or your belly. So, go ahead, take that inhale through the nose, feel the abdomen expand, and then exhale through your mouth. So when you take that inhale, the belly should feel like it's expanding like a balloon. And then the exhale should feel like your belly's just deflating like a balloon. So let's try a couple of breaths like that. Taking an inhale through the nose and then exhale through the mouth. One more time. Take an inhale through the nose and then exhale through the mouth. All right. Good job, everyone. I'm sure that your breathing was fabulous with amazing technique.
All right, does anybody have any questions for us? I'm going to pause sharing so we can monitor the chat. Give it a minute or two in case anybody has anything.
I'm just going to pop in here for a moment and say, thank you guys so much for your presentation here today while people are thinking of questions. I'm going to go ahead and put those links back in the chat again so nobody has to scroll up to find them. It looks like you have a couple of questions maybe coming in here. And I'm going to, again, remove myself from the situation. So go for it.
Our first question is, does insurance cover a visit? And yes, insurance usually does cover the first visit. Some insurance companies may require that you have a referral from your primary care provider or just another physician, so like an OBGYN as well. And so usually once you get that referral, they'll send it over to us and we call and make an appointment. But in the state of North Carolina, you are allowed to do direct access where you can come in and make an appointment yourself and get it covered. And usually the place, so I know here at Rex and at Durham, we do it, we get your insurance over the phone and run it through to make sure that it'll be covered. You may still have to pay a copay, and depending on the location, if it's hospital based, it may be a specialty fee. So it kind of varies from insurance to insurance company.
Any other questions?
Okay, I don't see any other questions coming in. Whoa, wait, there's one more. Okay, I'm gonna get out. Go.
Okay.
So go
Oh,
ahead, Jana.
okay, so the question is, how long do patients typically need therapy? My OB said 3 months possibly would not be sufficient. So, like I talked about earlier, generally we might see patients for 8 to 12 weeks, so that would kind of line up with that 3 months. But if you've had symptoms going on for a longer period of time, we might need a little bit more time to address your symptoms. So, it's hard to say how long we might see patients for because there are so many different factors that can play into it, but it can be longer than 3 months at a time. And then we would just collaborate as therapist and patient on time frame and what would work best for the schedule.
And one of the cool parts about therapy is that if you're not able, or we know it's going to be a long time, we can give you homework that you do at home and check in like every week, every other week, every 3 weeks, whatever works best for you. So the homework is the most important part to get us to help that problem move along. So one of the questions is how common is it to have increased feeling to need to urinate with perimenopause? And will estrogen help with that or pelvic floor PT? That's a really good question. It's very common to feel that increased urgency um, or that feeling like you're going to pee. And a lot of times, estrogen and pelvic PT will help. We see a lot of patients whose doctors have given them estrogen cream, and that estrogen cream helps kind of bulk up that tissue around the urethra. It's not like a physically noticeable difference, but gets that tissue back to a kind of a healthier state, more plump, and that can help support the urethra. So that way it's not always giving that feeling like we need to pee. And then usually people who have had that are at the point where they're leaking. And then once we've leaked, a lot of times we can get really nervous about leaking, and then that can lead to more leaking. So pelvic floor PT usually helps with the other end of that, or the impairments that can go along with feeling like you need to leak. Because usually if you feel like you need to leak, we squeeze so that way we don't leak. But then prolonged squeezing, as Gianna had said, can lead to pelvic floor dysfunction or impairments later on. So I would say both are really good options. You can always start with the estrogen cream, and if that doesn't fix fully everything, you can come visit pelvic PT. So, remaining on birth control during menopause, that's a discussion that's up between you and your doctors. If you are having a period, then you're able to get pregnant. So, that would definitely be something I would talk to your gynecologist about.
Okay, I think we're going to go ahead and wrap it up there for today. Thank you guys so much for your presentation today. I hope that everybody got something wonderfully educational out of that. If anybody missed anything or would like to watch it again, you can head over to our YouTube channel as soon as later this afternoon, and it will be there for, well, in perpetuity. So thank you all for joining us, and have a wonderful rest of your Therapy Thursday.